Welcome to this comprehensive lecture on acute epiglottitis, presented by Pediatric Case Review. Today we will explore this life-threatening airway emergency through case-based multiple-choice questions. We will cover clinical presentation, examination findings, pathophysiology, diagnostic investigations, treatment strategies, and potential complications. This systematic approach will help you recognize and manage this critical condition effectively. By the end of this presentation, you will understand the key differences between epiglottitis and similar conditions, ensuring prompt diagnosis and appropriate intervention to prevent airway obstruction and save lives. A 3-year-old child presents to the emergency department with sudden onset of high fever, severe sore throat, and excessive drooling. The child appears anxious and refuses to lie down. There is no cough present. What clinical triad best characterizes this illness? Option A, cough, rhinorrhea, wheeze. Option B, drooling, dysphagia, distress. Option C, fever, rash, conjunctivitis. Option D, nuchal rigidity, photophobia, headache. Take a moment to consider the clinical features before we reveal the answer. The correct answer is B, drooling, dysphagia, distress. This represents the classic 3DS of acute epiglottitis. The rapid onset with toxic appearance is characteristic. Difficulty handling secretions and air hunger are hallmark features. The absence of a barking cough favors epiglottitis over croup. These children appear severely ill and anxious due to respiratory distress. Early recognition of this triad is critical for prompt airway management and preventing life-threatening complications. A 4-year-old child is brought to the emergency department sitting upright, leaning forward with the chin thrust forward and mouth open. The child has hands placed on the knees for support. When staff attempt to lay the child down, respiratory distress worsens significantly. What is this classic position called? Option A, tripod position. Option B, sniffing position. Option C, Fowler position. Option D, lateral decubitus position. Consider why the child prefers this specific posture. The correct answer is A, tripod position. This posture optimizes airway patency and reduces the work of breathing by maximizing anterior pharyngeal space. It is commonly seen in epiglottitis and represents the body's compensatory mechanism. Never force a child with suspected epiglottitis into a supine position, as this can precipitate complete airway obstruction. Keep the child calm, comfortable, and undisturbed. Allow them to maintain whatever position provides the most comfort while preparing for definitive airway management. A 35-year-old adult presents with severe sore throat, painful swallowing, and muffled speech quality. The patient appears uncomfortable but is maintaining adequate oxygenation. Examination of the oropharynx appears relatively normal with no obvious tonsillar enlargement or exudate. Which examination feature most strongly suggests epiglottitis? Option A, muffled hot potato voice. Option B, uvular deviation. Option C, purulent anterior rhinorrhea. Option D, expiratory wheeze. Think about what distinguishes supraglottic from oropharyngeal pathology. The correct answer is A, muffled hot potato voice. The key diagnostic clue is disproportionate pain and voice change with a benign-appearing oral examination. This suggests pathology above the oropharynx in the supraglottic region. Voice changes are common in adults with epiglottitis, though drooling is less frequent than in children. The normal-appearing throat despite severe symptoms should raise suspicion for epiglottitis. Maintain high vigilance for potential airway compromise and involve otolaryngology and anesthesiology early. A 42-year-old patient presents with significant difficulty swallowing, painful swallowing, and fever of 39 degrees Celsius. The oral cavity examination reveals no obvious abnormalities, and tonsils appear normal. Which specific palpation finding would most strongly support a diagnosis of epiglottitis? Option A, maxillary sinus tenderness. Option B, hyoid or laryngeal tenderness. Option C, trismus with tonsillar bulge. Option D, thyroid cartilage crepitus. Consider the anatomical location of inflammation. The correct answer is B, hyoid or laryngeal tenderness. Pain elicited by gentle palpation over the hyoid bone or laryngeal structures is a reported clinical sign of epiglottitis. This external tenderness corresponds to the internal inflammation of supraglottic structures. When this finding is present along with odynophagia and voice changes, strongly consider epiglottitis. Early involvement of the airway management team is crucial. This simple bedside examination maneuver can provide valuable diagnostic information when other findings are subtle. A 6-year-old child presents with rapid onset of severe sore throat, high fever, and drooling. The immunization record confirms the child received all scheduled vaccinations, including Haemophilus influenza type B vaccine. Laboratory cultures are pending. What is the most likely causative organism in this vaccinated child today? Option A, Haemophilus influenza type B. Option B, Streptococcus pneumoniae. Option C, Mycoplasma pneumoniae. Option D, adenovirus. Consider how vaccination has changed disease epidemiology. The correct answer is B, Streptococcus pneumoniae. After widespread Haemophilus influenza type B vaccination programs, the microbiology of pediatric epiglottitis has shifted. Streptococci, particularly Streptococcus pneumoniae and group A Streptococci, have become more prominent pathogens in vaccinated children. Haemophilus influenza type B is now rare in immunized populations. In adults, the pathogen spectrum remains more diverse, and Haemophilus influenza still occurs. Understanding this epidemiological shift is important for appropriate antibiotic selection and patient counseling. A 2-year-old child with epiglottitis rapidly progresses from mild respiratory distress to severe inspiratory stridor and drooling within just a few hours. Which anatomical factor best explains why young children decompensate so rapidly with epiglottic inflammation? Option A, stiffer epiglottic cartilage in children. Option B, wider pediatric subglottis. Option C, ball valve effect from pliable epiglottis. Option D, longer pediatric trachea. Think about pediatric airway anatomy differences. The correct answer is C, ball valve effect from pliable epiglottis. In children, the epiglottic cartilage is more pliable and immature compared to adults. Combined with smaller overall airway caliber, this creates a dangerous ball valve mechanism. With each inspiratory effort, the swollen, floppy epiglottis is pulled down over the airway opening, progressively worsening obstruction. The epiglottis also sits more anterior and superior in children. These anatomical factors explain why pediatric patients can deteriorate dramatically and rapidly require emergency airway intervention. A stable adult patient presents with severe difficulty swallowing and muffled voice. The emergency physician orders a lateral neck radiograph to aid diagnosis while maintaining airway precautions. Which radiographic sign would suggest epiglottitis on this imaging study? Option A, steeple sign. Option B, thumb sign. Option C, curly B lines. Option D, air bronchogram. Remember that imaging should only be obtained in stable patients. The correct answer is B, thumb sign. The thumb sign represents an enlarged and edematous epiglottis visible on the lateral neck radiograph, appearing broad and rounded like a thumb rather than thin like a finger. However, imaging should only be performed if the patient is completely stable and never delay airway control for diagnostic studies. The sensitivity of lateral neck radiography is approximately 88 to 100%, but false negatives occur in 20% of cases. Clinical diagnosis remains paramount. A 28-year-old male presents with muffled voice and painful swallowing for 6 hours. Vital signs are stable with no stridor or respiratory distress at rest. The patient can handle secretions. What is the next best diagnostic step? Option A, tongue depressor oral examination. Option B, lateral neck X-ray immediately. Option C, flexible fiber optic nasopharyngoscopy. Option D, discharge with steroids. Consider safe evaluation methods in stable patients. The correct answer is C, flexible fiber optic nasopharyngoscopy. In stable adult patients, direct visualization by an otolaryngologist using flexible fiber optic laryngoscopy is the preferred diagnostic approach. This procedure should be performed with full airway backup available, including anesthesiology and emergency airway equipment. Fiber optic evaluation is superior to routine radiography in stable adults, providing direct visualization of supraglottic structures. Never use a tongue depressor, as this can precipitate acute obstruction. Maintain constant vigilance throughout the evaluation process. A 3-year-old child presents with severe drooling, inspiratory stridor, and sitting in tripod position. The child appears anxious and oxygen saturation is 88% on room air. What is the immediate priority? Option A, throat swab culture. Option B, visualize with tongue blade. Option C, airway stabilization with expert help. Option D, nebulized bronchodilator and reassess. Focus on what addresses the life-threatening problem first. The correct answer is C, airway stabilization with expert help. In a child with signs of airway compromise, securing the airway is the absolute first priority before any other intervention. Keep the child calm and avoid any agitating procedures. Do not attempt intravenous access, laboratory draws, or examination maneuvers that may precipitate complete obstruction. Prepare for controlled intubation in the operating room with anesthesiology and otolaryngology present. Have backup front-of-neck access immediately available. Antibiotics are important, but secondary to airway control. A 46-year-old male with acute epiglottitis has moderate supraglottic edema on fiber optic examination. He is cooperative in maintaining oxygenation but requires intubation for airway protection. What is the best airway management approach? Option A, rapid sequence intubation with paralytic. Option B, awake fiber optic intubation with backup tracheostomy. Option C, laryngeal mask airway as destination airway. Option D, deep sedation and blind nasal intubation. Consider techniques that maintain spontaneous ventilation. The correct answer is B, awake fiber optic intubation with backup tracheostomy. In selected cooperative adults with less severe edema, awake fiber optic intubation has high success rates when performed by experienced practitioners. This technique preserves spontaneous ventilation until the airway is secured. However, this requires an experienced multidisciplinary team including anesthesiology and otolaryngology. Full front-of-neck access equipment must be immediately available. Paralysis should be avoided as loss of muscle tone may cause complete airway collapse. Patient cooperation is essential for success. An adult patient with diagnosed epiglottitis is being monitored in the intensive care unit. The patient becomes progressively tachypneic and increasingly anxious despite supplemental oxygen. Which complication represents the most immediate life-threatening danger? Option A, pneumonia. Option B, epiglottic abscess. Option C, acute airway obstruction. Option D, vocal cord granuloma. Think about what can cause death within minutes. The correct answer is C, acute airway obstruction. Progressive swelling of supraglottic structures can lead to complete airway obstruction, resulting in asphyxia and respiratory arrest within minutes. This is the most feared and immediately life-threatening complication. Always anticipate potential deterioration and have a clear plan for emergency airway intervention. Front-of-neck access equipment should remain at the bedside. While pneumonia, abscess formation, and granulomas are possible complications, none carry the immediate mortality risk of acute airway obstruction requiring instant intervention. An 18-month-old child presents with gradual onset over 2 days of low-grade fever, barking seal-like cough, and hoarse voice. The child can drink fluids, and there is no drooling. Which clinical feature best supports croup over epiglottitis? Option A, barking cough without drooling. Option B, tripod posture. Option C, rapid high fever with toxic look. Option D, severe dysphagia with drooling. Consider the characteristic differences between these conditions. The correct answer is A, barking cough without drooling. Croup involves subglottic swelling and presents with characteristic barking cough, gradual onset, and typically a non-toxic appearance. The steeple sign is seen on radiography. In contrast, epiglottitis features the 3DS, drooling, dysphagia, and distress, with rapid progression and toxic appearance. Epiglottitis patients notably lack cough. Understanding these distinguishing features is crucial for appropriate triage and management. While both can cause stridor, the overall clinical presentation differs significantly between these two airway emergencies. This comparison table highlights the key differences between 3 major pediatric airway emergencies. Acute epiglottitis presents rapidly with high fever, no cough, and the classic 3DS of drooling, dysphagia, and distress. The thumb sign is visible on lateral neck radiography. Croup develops gradually with low-grade fever, characteristic barking cough, and the steeple sign on imaging. Bacterial tracheitis often presents as severe croup that fails standard treatment, with thick purulent tracheal secretions and toxic appearance. Recognizing these distinguishing features enables rapid diagnosis and appropriate management tailored to each specific condition. Join our exclusive pediatric case review community on Patreon for enhanced learning resources. All our educational videos are systematically organized by body system, making it easy to find exactly what you need. You will have access to all presentation slides in photo format, allowing you to read and practice all questions at your own pace. This comprehensive resource library helps reinforce learning and serves as an excellent review tool. For complete details about membership benefits and subscription information, please comment below on this video and we will personally message you with all the information. We have completed our comprehensive review of acute epiglottitis through 12 case-based questions. Remember, airway management is always the first priority in suspected epiglottitis. Diagnose safely using appropriate methods for patient stability. Treat promptly with expert multidisciplinary involvement. Please follow Pediatric Case Review for more informative medical education presentations covering essential pediatric emergencies and clinical scenarios. If you have any questions or topics you would like us to cover, please leave a comment below. Thank you for watching and continue learning with us.